So our next speaker is Professor Randall Packard, who many of you know. He is the William H. Welch Professor of the History of Medicine at Johns Hopkins University School of Medicine. And his research spans the social history of disease, health, and healing in Africa, the history of public health, and colonial and post-colonial medicine. He's written a number of very important books. I mean, books. He's actually a hero of mine. So books that have really shaped, the way we all think about tuberculosis and disease. And most recently, he's written just a fantastic book on the history of global health. So I can't think of somebody better suited to really talk to us about the historical perspective on accountability in global health. Professor Packard.
So first of all, thank the organizers for inviting me and for including history in this discussion. History has an important role to play. And we're going to do a kind of deep dive into history. I took on the task of talking about the history of accountability from colonialism to the present, which is like extraordinarily large as I realized I got into it. I apologize in advance for those who've read the paper and for the talk that you sort of have to skim along the surface a lot, and there's generalizations that hopefully we can dig down into. But I'm hopefully to give you a sort of larger context in which we can frame our discussion, and many of the things that have been said already, I think, fit into what I'm trying to do here. I will say that because it's so long, the only way I'm going to get through it is I read most of it, so I apologize in advance for that. Since the beginning of the 20th century, international and global health organizations have invested billions of dollars in efforts to improve the health of peoples living in resource-poor areas of the globe. Most of these efforts have been focused on the organization of vertically organized disease control efforts and the use of biomedical technologies such as vaccines, antibiotics, insecticide-treated bed nets, and birth control pills. These technologies have been delivered through vertically organized programs designed in places like Geneva, Atlanta, Washington, London, Paris, and recently Beijing, with little or no participation of those who are the targets of these interventions. This top-down pattern of global health decision-making raises several questions about global health accountability that I want to explore this morning, or it's actually this afternoon. First, to whom are those who design and implement global health programs accountable? Secondly, how have patterns of accountability changed over the course of the 20th and 21st centuries? How is accountability measured? What kinds of mechanisms, metrics, evidence have been used to account for and demonstrate the results of health interventions? And finally, how have these methods changed over time? Now, as I said beginning, I'm going to trace the history of accountability from the era of colonial rule through the current period, and going through 6 phases, which I outline in my book, and which most people interested or knowing knowledge about the history of international global health already know about. The era of colonial and early international health campaigns, social medicine and rural hygiene movement during the 1930s and 40s, the era of disease eradication in the 50s through the early 70s, then the quick move to primary health care and short move to primary health care in the 1970s, and the return to selective primary health care in the 80s and 90s, and then finally to global health. Sounds like a lot, but hopefully we can get through it. So, while global health decision-making has generally flowed in an upward direction, accountability has moved in the opposite direction, with those implementing programs reporting upward to those organizations which have planned and or funded interventions. Conversely, there has been very little attention paid until recently to the need for downward accountability, that is, accountability to those who are supposed to benefit from health interventions. And I want to stress here that true accountability requires participation in the planning and evaluation of interventions. There are exceptions to this pattern, and these exceptions often corresponded to periods that witness a broadening of the visions of health approaches that occurred, for example, in the 30s and then in the late 70s. But there have also been exceptions during earlier periods associated with highly vertical programs to health. And it is important to understand why these exceptions have occurred, and we'll talk a bit about that. Finally, even when the need for accountability to those who are the recipients of public health interventions is recognized and even promoted, the mechanisms through which accountability is imagined to occur have often been weak and lacked methods of enforcement. They also fail to address power differentials which serve as barriers to accountability. Health interventions under colonial rule were basically put in the hands of three different groups: colonial health services, faith-based organizations, missionaries, medicine in particular, and private corporations, mines and plantations. And each group had its own mission and its methods of accountability. Now, I discuss colonial medicine and accountability in the paper, but because of the time restraints, I'm going to skip over it and simply say the obvious point that accountability for all three of these groups was almost exclusively upward, to colonial offices, religious order headquarters, and to stockholders. However, I'll add one caveat, and that is while there was little in the way of official downward accountability, colonial subjects were able to shape and modify health interventions through responses and, in some cases, resistance to these interventions. For example, Mary Wiebel's work on the history of sleeping sickness, control activities instituted by the Germans in East Africa in the early 20th century, shows how the placement of sleeping sickness camps and the identification and treatment of Africans afflicted with sleeping sickness was greatly influenced by the action of local African authorities. Throughout the history of international and global health, local populations have played an important, if informal and seldom acknowledged, role in shaping programs in the absence of formal channels of accountability. And we saw this in the Ebola outbreak and how little accountability locals had for what that was done to deal with that outbreak. While colonial medical authorities, missionary doctors, and private corporations continued to provide biomedical services through the middle of the 20th century, they were joined by newly formed international organizations which initially augmented colonial health services, and these included the League of Nations Health Office, the network of Pasteur Institutes, and the Pan American Sanitary Bureau. The largest and most influential of these, however, was the Rockefeller Foundation. The foundation created an International Health Commission in 1913 with the goal of extending the foundation's efforts to eradicate hookworm in the American South and to other countries around the globe where hookworm was incapacitating millions of people. The Commission, which changed its name to International Health Board in 1916 and the International Health Division in 1927, became the most powerful and influential international health organization during the first half of the 20th century. The main focus of the International Health Board's activity was disease campaigns against hookworm, yellow fever, and bilharzia. The hookworm campaign was typical of the Foundation's approach to disease and to accountability. Accountability within the International Health Board was always a complicated matter. IHB officers were ultimately responsible to the Foundation headquarters in New York. Yet the Rockefeller Foundation entered complicated contractual relationships with governments in the countries and colonies within which they worked, and they depended on these organizations and governments for cooperation. IHB officers were therefore accountable to local governments as well as to New York. Accountability in the hookworm program's evidence of program success was measured in much the same way as the success of disease control programs during colonialism. And that is number of peoples who were treated. Program officers equated treatment with cure, and the Foundation reported the percentage of people in a country or region that had been cured from hookworm. But claims of treatment equaled cure ignored the reality that many of those cured were going to be reinfected due to lack of successful sanitation efforts, including the building of latrines. IHB medical officers had little patience for sanitary work and made little attempt to understand the perceptions of local populations and the conditions under which they lived and how these might impact the adoption of sanitary measures. In Trinidad and British Guyana, sanitary efforts ran into local resistance to building latrines, both because the latrines were expensive to build and because in most cases, it conflicted with local cultural attitudes regarding excreta. In Costa Rica, local populations complained, rightly, that the latrines attracted mosquitoes and then led to increases in malaria. The failure of IHB officers to understand local attitudes and conditions reflected a larger absence of any efforts to engage or seek the counsel of local populations. It reflected a lack of downward accountability. Ironically, the absence of downward accountability undermined the ability of program officers to accurately measure and report the impact of the programs they were running. It underestimated, or it undermined, upward accountability. Field officers were often criticized by IHD statisticians for not collecting adequate data and for making claims that were not backed up by actual data. Lack of downward accountability was also evident in the Foundation's response to the deaths of children who had been treated by oil of chenopodium in Colombia. As Steve Palmer has shown, between 1914 and 1934, IHB documented over 200 deaths from oil of chenopodium intoxication. More than 80% of these were in children under 12 years of age. The Foundation's initial reaction was to deny that the toxic drugs had caused the deaths. Yet the Foundation had evidence of the drug's toxicity, particularly in children under 12, by 1926. Pressure from below in the form of protests of Columbia physicians who were involved in running the program eventually forced the Foundation to acknowledge liability for some of the children's deaths and to pay compensation in at least one case. It was a rare example of the Foundation being made to be accountable to the population being treated, and it reveals an important theme in the history of accountability in global health. Accountability downward rarely occurred without pressure or resistance from below. Downward accountability in international health organizations increased during the 1930s, as both the League of Nations Health Office and the Rockefeller Foundation's International Health Division launched a series of integrated rural hygiene initiatives in China and Southeast Asia. These were part of a broadening of international health activities beyond the organization of vertical disease campaigns like the Rockefellers' hookworm and yellow fever campaigns. This broadening reflected the rise of social medicine in Europe and the effects of the global depression, which had laid bare the links between poverty and health. The League of Nations organization, led by Ludwig Rachmann, viewed the organization's relationship with China as one of equals. He had a high regard for Chinese officials who staffed the country's various ministries, many of whom had been trained in the West. He also believed that the League should respect Chinese nationalist aspirations and not try to dictate policies to them. Importantly, he employed the term technical collaboration rather than technical assistance, which has been used for a long time in international health activities and is dealing with the Chinese. Similarly, the Rockefeller Foundation's International Health Division engaged in the building of an innovative health and development program in North China. The Foundation's program in the 1930s was the brainchild of Seltzer Gunn, the Foundation's vice president and director of the IHD European program. Gunn's social reform vision was in turn stimulated in part by Y.C. Yen, a Yale-educated Chinese promoter of education. Yen had founded the mass education movement, a literacy campaign, and by the mid-1930s, Yen claimed to have provided basic reading skills to 40 million Chinese. He then expanded his educational activities to include scientific agriculture, cooperative marketing, public health, and government integrity. The public health activities promoted by Yen were directed by Chinese physician C.C. Chen, who had a degree from Harvard, by the way. Chen developed a program that was based on the utilization of local resources and the concurrent improvement of social and economic conditions. At the village level, health stations were staffed with village health workers, local people who had received basic training in preventive treatment and simple medical procedures. They were responsible for first aid, vaccination, the reports of births and deaths. They also oversaw improvements in sanitary conditions, especially the constructions of drinking wells and latrines. The North China Integrated Health Program was thus created in a partnership with Chinese health officials and drew much of its inspiration from their work. It also engaged local health workers in the organization and implementation of the program. It marked a significant departure from the top-down vertical programs of the teens and 20s and was much more accountable to local actors. Interest in rural reconstruction and hygiene outside of Europe culminated in August 1937 with the Intergovernmental Conference of Far Eastern Countries on Rural Hygiene, held in Bandung, Java. One of the main foci of the conference was rural reconstruction. Discussions of rural reconstruction centered on the problem of obtaining the collaboration of local populations. The conference report concluded, whether in the matter of housing or diets, sanitary arrangements, or treatment of disease, it is necessary to work through the people and avoid, as far as possible, imposing systems from above. This marked a clear departure from the pre-Depression forms of international health and accountability. Many of the ideas that had guided the activities of the League of Nations Health Office and the Rockefeller Foundation's International Health Division during the 1930s survived the war and guided the creation of a series of new international health and development agencies, including the newly formed World Health Organization immediately after the war. Yet, by the early 1950s, international health assistance resembled the early activities of the Rockefeller Foundation International Health Division, with a focus on vertical disease elimination programs, more than the integrated and participatory programs envisioned by the Bandung Conference. The development of new biomedical technologies in the form of antibiotics, pesticides engendered a new culture of development, reigniting faith in the ability of public health leaders in Europe and the United States to improve the health of peoples living in resource-poor countries in Africa, Asia, and Latin America. Even in the area of reproductive health was seen as an issue of technology, as shown in this poster, which is, of course, one of these ones that shows an unhappy woman with lots of children, a happy woman with one child, but it's thinking of all of these wonderful technologies that'll get her there and basically ignores all the underlying social determinants of reproductive decision-making. The culture of development that emerges during this period combined this sort of faith in the ability of technology to bring about improvements in health. On the other hand, discounted the ability of local populations to do anything on their own to take care of their health. And this view was reflected in this particular quote from a U.S. Department of State report on Point 4 program. The most dramatic results from the employment of a very small number of skilled men in very small quantities of scientifically designed materials have been achieved in the field of medicine. In many areas of the world, one trained public health doctor or a group of 2 or 3 working with local people able to follow their guidance have been able to rout one of man's oldest and deadliest diseases. Downward accountability during the 1950s and 60s was significantly curtailed, even though the structures of WHO, which played a central role in directing international health initiatives during this period, enabled member countries to express their concerns about which health interventions should be funded and to receive feedback on the progress of various interventions. Given that Marcos's paper focuses on the history of accountability within WHO, I will not attempt to address this issue in any detail here. However, a couple of general points needs to be made. First, the WHO was less participatory, democratic, and accountable than its constitution implied. During most of the 1950s and 60s, membership of WHO was dominated by countries in the Americas and Europe. Most of the countries that were recipients of international health assistance were represented by colonial rulers. Secondly, even after decolonization and the growth of a number of non-European or American member states, several countries, and particularly the United States, possess considerable power over the direction of WHO because they provided the largest financial contributions to the organization's central budget. The US also had the right to withdraw from the WHO if it didn't like what its policies were. Finally, much of the power of WHO was held by the Director General, who until recently was elected by a very undemocratic process that favored candidates supported by powerful governments, as Marcus's paper shows. Secondly, the accountability of WHO-led interventions to local populations was limited. At best, it involved the creation of culturally appropriate messages, often designed by anthropologists, to convince local populations to adopt externally defined interventions. However, as with colonial and IHD health interventions, WHO efforts in the 1960s and 70s were shaped by the actions of local leaders and populations faced with health interventions opposed from above with little consultation. Thus, local populations were able to impose some degree of downward accountability. For example, as Christian Macmillan has shown, the WHO ran into resistance in Madras to the international BCG vaccine campaign, A.V. Rahman, a former sanitary engineer, published a series of editorials criticizing the use of BCG in India in his monthly publication, People's Health. Rahman criticized the Indian government for favoring technical solutions over sanitary reforms, clean drinking water, proper housing, and sewage. He also raised concerns about the uncertainty surrounding the efficacy and safety of BCG, and he accused the campaign and the Indian government of using Indian children as guinea pigs. Rahman's attack gained momentum, and local health authorities and politicians began withdrawing their support for the project. In the autumn of 1949, the Madras provincial government opted out of the Union government's plan to intensify BCG vaccinations. The campaign eventually moved forward, but not before the organizers were forced to develop an education campaign aimed at discrediting opposition, but also promoting the benefits of BCG. This was a case of local resistance forcing WHO to be accountable to local concerns. It reinforces the importance of resistance in ensuring accountability. The discovery of the last case of smallpox in Somalia in 1977 marked the successful completion of the eradication campaign, and it represented the pinnacle of success for global post-war vertical disease control programs that had dominated WHO's activities during the 1950s, 60s, and 70s. Yet 1 year later, the world of international health made what appeared to be an about-face and returned to an approach to international health that was much closer to that of the 1930s than it was to the 50s and 60s. Primary health care, as defined by the Alma-Ata Declaration in 1978, represented a rejection of vertical program design in distant capitals and a commitment to building programs from below, reflecting the interests and needs of the people. The rise in primary health care was driven by widespread critique of the role of biomedicine in advancing health and an appreciation of the successful primary health care initiatives in China and other places. Equally important was a growing critique of the failure of earlier development efforts to reduce poverty. The development decade of the 1960s had led to economic growth without development. The critique came from organizations like the World Bank, but also powerfully from the developing countries whose leaders called for the creation of a new international economic order. They also called for new forms of accountability. The new health system should be accountable to the people. As before, pressure from below was critical to efforts to make international health assistance accountable to the recipients of aid. The shifting of health resources to a system of primary health care built with the full participation of local populations was the cornerstone of the primary health care movement as envisioned by advocates of primary health care. It was, however, a vision that was difficult to put into practice. There were many reasons why the PHC movement failed to achieve its goal. Redirecting health resources from tertiary to primary care proved to be much more difficult than imagined. The onset of the global recession in the 70s and 80s greatly reduced the financial resources available for building health systems. The rise of neoliberalism in the 1980s also created an environment which discouraged government spending on health systems and promoted market-based solutions to healthcare. Yet PHC also had internal weaknesses. Among these was a lack of structures that would ensure accountability and methods to measure accountability. While the Alma-Ata Declaration set up a vision for PHC, it did not provide a blueprint for building PHC systems. Moreover, the BHC vision was based on an idealized view of rural societies in which democratic processes naturally occurred and popular participation could easily be organized. Hierarchical structures dominated by men was much more common. Efforts to democratize decision-making by outside NGOs often met with resistance. There were successes, but reproducing these successes, especially in the changing economic and political environment of the 1980s, was exceedingly difficult. Equally important, successes were difficult to measure in terms of specific indices. In other words, the mechanisms for measuring accountability were inefficient. Measuring accountability, as before, required the collection of accurate baseline data on health status of populations and then surveillance systems that measured changing health patterns. Few PHC programs succeeded in developing these systems. While it was clear that more people had access to basic care, it was difficult to document the difference this made in the overall health status of the populations being served by primary health care programs. One of the few programs that did create a system for measuring outcomes was the Jamkhed Comprehensive Rural Health Project in India, which delivered both preventative and curative health care to some of the most vulnerable poor people in rural, drought-prone areas of India. It was designed to be community-based and was implemented with the cooperation of local populations. The CRHP recorded significant improvements in the health of the communities it served. These statistics produced by the CRHP, shown here, were exceptional not only for what they showed in terms of program impact, but also because few primary healthcare programs were able to document this kind of success. Lack of statistical evidence limited the ability of PHC programs to demonstrate the success they were having. This limited their upward accountability and their ability to convince donors that primary health care was more cost efficient than selective interventions. Within the changing environment, political and economic environment of the 1980s, efforts to build primary health care systems were quickly replaced by a return to more selective approaches to health care based on the application of simple biomedical technologies. The new approach was known as selective primary health care. From its beginnings in meetings in New York and Bellagio in the 1970s and early 80s, selective primary health care was shaped by the need to develop an effective measures of accountability. These measurements were designed to demonstrate the impact of interventions to donors and planners. This picture of participants at a 1984 Child Survival Conference in Bellagio tells you most of what you need to know about the absence of downward accountability in international health at that time. In an early meeting in New York to discuss methods of rapidly improving the health of children across the globe, former World Bank President Robert McNamara urged Jim Grant, newly appointed president of UNICEF, to employ approaches that could be counted. Grant hardly needed to be convinced. He wanted to reach 400 to 500 million children in the developing world and the 100 million that were being born into it each year, providing them with immunizations, rural rehydration kits, and other appropriate technologies that could save millions of lives at a time and could be measured. Grant became a leading advocate of selective primary health care approaches to global health, as we know. Yet counting interventions were not the only measure of accountability that became central to selective primary health care revolution. Cost effectiveness became a central criterion by which one judged the value of health interventions in the 1980s. Cost effectiveness reflected the need to maximize the impact of dollars spent on health interventions in terms of the cost per life saved. The principle was employed in a paper presented by Judith Walsh and Kenneth Warren to argue for selective primary health care at a meeting attended by the heads of several international health organizations in Bellagio in 1979. Cost effectiveness was a form of accountability that appealed to donors, and particularly the World Bank, that was beginning to ramp up its involvement in international health funding. It was equally attractive to other donors, and particularly to Reagan-era politicians who were critical of government spending on health care and viewed existing health programs as inefficient and wasteful. The critique of government spending on health interventions and on health care was embedded in structural adjustment policies imposed by the World Bank and the IMF on developing countries. In the wake of global recession and in response to the rising international debts, in return for the debt relief, governments were required to cut spending on social services and in subsidies to such things as food and agriculture. They were also encouraged to decentralize healthcare spending, with a greater share of financial burden being placed on the consumers of healthcare. In place of central government expenditures, local populations could pay user fees. Investments in health were also increasingly funded through non-governmental organizations rather than state-run health systems. SAPs led in many places to a decline in healthcare usage, and the poor could not afford to pay user fees. In Zambia and other places, users' fees led to a major drop in clinic attendance. In some cases, it also led to an overall decline in health. However, SAPs did not lead to an increase in upward accountability, since it limited the ability of health systems to measure outcomes. User fees were charged for the services provided for health consumers, and even where people could pay these fees, they did not cover the costs of public health programs aimed at protecting populations, including health education, sanitation, routine house spraying to prevent malaria, and epidemiological record keeping. These services declined or ceased to occur. It would be a mistake, however, to see accountability under selective primary health care as solely about responsibility to donors and thus directed upward. In an odd twist, the neoliberal attack on government spending opened new opportunities for community participation and thus downward accountability. It led to new interventions aimed at softening the blow that structural adjustment had had on health care, or in Jim Grant's words, to produce adjustment with the human face. These new policies were rolled out at a meeting of representatives of the WHO and UNICEF and African heads of states at Bamako, Mali in 1987. The meeting encouraged countries to adopt measures that continue the emphasis on decentralization, self-financing, and user fees, but which also encouraged popular participation. Bamako initiatives focused on the delivery of drugs through community-run financial mechanisms and stimulated the creation of community health projects in several African countries, including Kenya. Through Bamako initiative projects, the national government tried to fill gaps in their country's health infrastructure by establishing markets. In doing so, Bamako initiatives, in theory and sometimes in practice, produce mechanisms of accountability at the local level. Yet over time, markets collapsed as consumers were unable to repay their loans or drugs for drugs, nets, and other health commodities. Bamako initiatives were unable to counter the effects of structural adjustment and the inability of many of the poorest of the poor to participate in health markets. In many ways, global health extended the principles that guided selective primary health care. A focus on the application of targeted biomedical technologies, vaccines, vitamin A supplements, ITNs, emphasis on cost effectiveness of interventions, a continued reliance on markets and non-governmental organizations, and a growing emphasis on counting. There was at the same time an increased concern about accountability, especially upward accountability. Expanding funding for international health activities was sparked initially by the AIDS pandemic, followed by rising concern about the threat of emerging infectious diseases and bioterrorism. This concern gave rise to a set of new organizations, which included public-private partnerships like Rollback Malaria and the Global Alliance for Vaccines and Immunizations, large private foundations like the Bill and Melinda Gates Foundation, and new funding mechanisms like the Global Fund for AIDS, Tuberculosis, and Malaria. It also led to increased funding by the World Bank and bilateral organizations, including USAID, DFID, and the Chinese Department of Foreign Aid. Finally, global health involved a massive growth in the number of NGOs dedicated to health. At the same time, the influence of the WHO declined in the face of steep cuts in the central operating budget and a growing critique that it had become ineffectual and bogged down by politics. With the declining influence of WHO and the growing influence of less representative organizations like the Gates Foundation, PEPFAR, and the Global Fund, the focus of international health decision-making in the early 21st century moved even further away from the places and people receiving the vast majority of global health assistance, limiting global downward accountability. These developments nonetheless were accompanied by calls for greater accountability and transparency in global health. Major donors, and particularly the US government under the Bush administration, argued that the existing aid organizations within the UN system were inefficient and lacked adequate mechanisms for ensuring accountability. Funded programs needed to both keep track of funds that they received and demonstrate impact. The World Bank had begun to insist on performance-based funding and evidence of cost effectiveness in the 1990s. It adopted a system of measuring the effectiveness of health interventions in terms of numbers of disability life years or DALYs it saved, along with the cost of lives saved. The Gates Foundation, through its billion-dollar investment in Gavi program beginning in 2000, also developed performance-based models that required grant recipients to demonstrate results and doled out monies in small tranches, with each subsequent payment dependent on demonstrated achievement. To enforce this model, the foundation implemented a system of audits, including surprise visits on development sites. Global health organizations also began setting performance standards for countries to meet. For example, the 2000 Rollback Malaria participants set a threshold of 60% coverage for its various interventions it supported, including insecticide-treated bed nets for reducing the burden of malaria. This goal was supposed to be met, but was not in 2005. It's important to recognize, however, that much of the early concern about accountability within global health was targeted at increasing accountability to funders, not to the countries or populations targeted for interventions. The Global Fund, however, was established with both upward and downward accountability in mind. Its funding mechanisms were designed to ensure accountability at all levels and high degrees of transparency. I want to take a couple of minutes here just to look at the fund's activities because it shows that even with the best intentions, accountability is difficult to achieve. Downward accountability was built into the way funding requests were organized. Funding requests had to come from a local level committees referred to as country coordinating committees, which were composed of countrywide coalitions of stakeholders that included government officials, NGOs, and representatives of civil society. The Global Fund's promotion of CCMs represented a commitment to grassroots participation, yet it also reflected the fund's distrust of national governments. While the Global Fund encouraged country ownership of programs, the fund's proposal review process and project monitoring mechanisms tended to undercount country ownership. The technical review panels set up by the Global Fund were staffed by experts who lacked direct knowledge of local conditions in the countries applying for the funds. Project evaluations and suggestions for revisions were therefore based on whether the proposals met a set of external technical criteria rather than on whether they made sense in terms of local conditions. Secondly, to ensure fiscal accountability, the Global Fund required that each country have a local fund agent who was responsible for monitoring project finances. The fund employed several established international accounting firms to serve as LFAs for many recipient countries. Subsequent reviews of the Global Fund's activities revealed country-level concerns about the failure of the fund to employ existing monitoring mechanisms and lack of country-specific expertise among appointed LFAs. The LFAs further undermine the principle of country autonomy and accountability. The proliferation of donor organizations and NGOs created new kinds of accountability issues. NGOs filled the void left by the retrenchment of government health services under the pressure of economic austerity policies. NGOs often operated independently of national health services and primarily were accountable to the organizations that funded their projects. Even projects that were designed to build participatory community health projects ultimately were accountable to their funders. In addition to upward and downward accountability, we're now increasing needs for accountability across organizations and few mechanisms to ensure that it occurred. Proposals generated by the bank to create common funding baskets into which various aid organizations would contribute funds to support a strategy developed at the country level proved difficult to manage. The need for accountability also led to an increase in reliance on evidence-based interventions. Randomized controlled trials became the central tool for evaluating the effectiveness of global health interventions, and the use of research trials to test public health interventions was not new. Trials had occurred for drugs and pesticides before, but it was ramped up greatly during the 1990s and 2000s. The use of RCTs was also fueled by a rapidly expanding academic research enterprise funded by multinational organizations, bilateral donors, and the manufacturers of pharmaceuticals and biomedical devices. I'm running way over time now. Sure. Global health research was frequently undertaken in collaboration with local researchers. They also had to be cleared by local IRBs. In theory, therefore, there was some accountability at the local level for global health research projects. However, these collaborations were often unequal partnerships. While local researchers in Brazil and India, which possess relatively strong institutions and resources, played a significant role in shaping research agenda, their counterparts in resource-poor countries in Africa, where hundreds of millions of dollars were spent on trials related to AIDS, malaria, and other diseases, had less influence. As Joanna Crane has shown, African researchers made significant contributions to these projects and published papers derived from their work. Yet researchers and institutions located in the global north controlled the funding sources and thus overall design, direction, and choice of interventions to be studied. The growing reliance on RCTs, which often cost millions of dollars to conduct, reinforced the power of donor organizations and limited the role of local researchers and health officials in defining the direction of health interventions. Equally important, these same researchers and institutions in the global north dominated international committees, funding panels, and editorial boards of major medical and public health journals. They had the power to determine which studies were funded, published, and validated. The history of the struggle between international advocates of vitamin A supplementation and local researchers who struggled to publish studies that challenged the effectiveness of this intervention in India highlighted the uneven playing field on which global health research is conducted. It took over a decade before Indian researchers could get their million-child study published in The Lancet. The growth of evidence-based health in RCTs had collateral effects. First, it privileged certain kinds of interventions over others. RCTs were designed to test the efficacy of biomedical interventions and privilege interventions that could be easily counted, and not to broader efforts at improving health systems, access to clean water, and sanitation. They contribute to what anthropologist Ken Adams, which is noted before, called an audit culture in global health. Equally important was the tendency to generalize the findings of an intervention that had been tested in a few sites to populations across the globe. Bed nets and vitamin A supplements are examples of this. Vitamin A supplementation was promoted across sub-Saharan Africa after only 2 trials, which had contradictory findings. And they were conducted with very unreliable data on the actual prevalence of vitamin A deficiency in most countries. African health ministers were pressured into adopting an intervention without evidence either of its local need or efficacy. RCTs had the power to undermine local accountability. So, from the period of health interventions at the beginning of the 20th century to the present, accountability has been an issue in the management of health interventions. For most of this period, accountability has been directed upwards to those who planned and funded interventions, often with limited data. Accountability demands investments in the infrastructure needed to collect and analyze basic demographic data, as well as the health status of population, as Margaret Chan has noted in this quote. Downward accountability has been limited. As I showed, there have been times when there's been more accountability than other, and there has been accountability largely as a result of resistance from below. Yet much of what counts as accountability continues to be designed to demonstrate effectiveness to donor organizations and countries. Even where efforts have been made to ensure downward accountability, as in the funding mechanisms of the Global Fund and the system of common funding baskets proposed by the World Bank, downward accountability remains limited. Moreover, the new forms of counting, the heavy reliance on RCTs, and the inequalities embedded in the system of global health research have reinforced this trend. To ensure future downward accountabilities, country and local populations need to be empowered to challenge interventions deployed without their participation. The history of earlier interventions suggests strongly that downward accountability only occurs where local populations have the power to resist. This is not easy to achieve. At the national level, it means building research capacities and strengthening health systems where they do not currently exist. In sub-Saharan Africa, the research capacity of a number of African countries has increased substantially over the last 2 decades. But African researchers are major partners in global health research, yet few countries possess the financial resources needed to fund their own research trials and meet international standards without external funding. In addition, IRBs have been limited in their ability to turn down externally defined research projects for fear of losing research dollars. Research and program implementation partnerships need to be between equals. At the same time, international review committees need to have members who understand local realities and not just technical experts. There is also a pressing need to examine peer review process by which grants applications are evaluated and publications judged. Both processes currently place too much power in the hands of a relatively small group of experts from the global north and do not adequately represent the views of local researchers. At the population level, the needs of local communities must be recognized and built into programs of development. CCMs, if that's what they're going to be used, need to have more power to design programs and to meet local needs and not just technical standards. They also need to be able to demonstrate success through the collection of basic economic data. Ultimately, better data and mechanisms for accountability are not going to solve the health problems of the world's poor. Economic advancement, access to education, and serious commitment to building health systems and to addressing the social determinants of ill health are essential. None of this will be easy, but acknowledging the problems that currently stand in the way of accountability is an important first step. And I thank you for your patience on this overly long historical journey.